Hi everyone, my name is Usha Tedrow and I'm from Brigham and Women's Hospital in Boston, but I'm also one of the associate editors here at JACC, and I'm really happy to be here with Gurukripa, who's going to talk to us today about his new paper that's being published. Could you introduce yourself for just a moment and tell us a little bit about the subject of your paper?
Absolutely. Thank you so much, Dr. Tedrow. My name is Dr. Gurukripa, one of the cardiac electrophysiologists at Mayo Clinic in Rochester, Minnesota. I'm here to talk about our paper, which is failure of intrinsic AntiTachycardia pacing to treat ventricular tachycardia and potential proarrhythmic effects.
Thank you so much. Could you tell us a little bit for our viewers what is IATP and how does it work?
Absolutely. So all of our viewers must be aware of the traditional ATP, which is pacing the ventricle faster than the VT cycle length to terminate VT. So Medtronic came up with this new algorithm, which is intrinsic ATP. What it does is it delivers some paced beats that are faster than the VT cycle length, about 88% to be specific, and delivers an extra stimulus. The idea is to get into the circuit a little better, a little faster to try and terminate VT to be more effective than our traditional ATP.
And has it been effective in previous studies, do you think?
Yeah, there have been single arm studies without a comparator arm looking at patients who had VT and then using this new algorithm, and it does seem to be at least as safe and effective as a traditional ATP, but there haven't been direct head-to-head studies. There's one that was done with a virtual modeling for VT, and then they saw that in that paper traditional ATP was inferior to intrinsic ATP in terminating VTs, but we haven't had real-world data.
Yeah, and so what did you find in your real-world experience?
Yeah, so we had 4 patients that we treated at Mayo Clinic who presented with VT and ICD shocks in 2 of them, and then accelerated VT in 2 others. And then when we analyzed the algorithm and the data from those patients, we saw that intrinsic ATP ended up accelerating VT in all 4 of them. 2 of them went into the VF zone and required shocks, and the other 2 also were in the fast VT in the VF zone, but had type 2 breaks. So fortunately, did not get ICD shocks.
I see. This is such important information. How do you think the clinicians should respond to your paper?
Yeah, so I think it's important to be aware that this algorithm is nominally turned on. So for clinicians to look at the individual patient in front of them and see that will be appropriate for that patient. In the studies I mentioned, we saw that the VT cycle lengths, when they're faster to begin with, there's more likelihood of acceleration of VT. So maybe if you have a patient who has a lot of scar and VT cycle lengths are faster than 300 milliseconds, maybe be a little bit more careful in those patients. If you do experience a patient who has had proarrhythmia because of IATP, maybe turn it off or maybe do a non-invasive program stimulation to see if you can program around that.
Fantastic. Thank you so much. And check out the details of the paper if you'd like more information on the JACC website.
Thank you so much.